Hi, folks. How you doing? Chris Wilson, Modified Independence, here with another installment of what I'm calling I'm getting ready to have surgery for a knee or a hip replacement or a lower extremity surgery, and I need to know what to do to make my home safer. Oh, it screws backing out. All right. Well, that's what you get for using a used walker. Um, so this is today. I'm working with a rolling walker. You can see there's a tennis ball over here. I think the tennis ball wore out over here. I've already done the service of putting the wheels on the inside. They come shipped with the wheels on the outside, which means that this leg's over here and this leg's over here, just for space considerations and because most people don't like scratching up their walls with these bolts that stick out. Typically, when I find somebody, I'm going to switch these legs and put the wheels on the inside because then there's nothing to scrape except for your knuckles, and knuckles don't make as much of a dent in the drywall, but they do get bruised up pretty easily. So this is a series of videos that I decided to make because my company wants to work very closely with orthopedic surgeons in the area because most lower extremity joint replacement surgeries are actually planned. These people are aging. They've got worn out hips and knees. These appointments are scheduled months in advance because they have to go to their cardiologist, or rheumatologist, or pulmonologist, or kidney doctor, endocrinologist. I was going to think of the word eventually. They're going to go to these people and they're going to get medically cleared in order to be able to have that surgery because they have to go under anesthesia and they have to go on antibiotics and everything like that. So there's plenty of time in advance that these surgeries are actually scheduled, which means that they're probably not getting in-home services. They don't need them. Obviously, if they got a bad knee or a bad hip, why are we trying to exercise them? They don't need the repetitions on the joints. If you're a PT and you disagree with me, feel free to hop in the comments and tell me what you think a patient is going to gain by doing exercises while they're on pain medications and blood pressure medications that they wouldn't have already gained by just doing their exercises before all of this happened. Feel free. I'm interested to hear your comments. This channel is for us as therapists and patients to be able to talk, but I just don't see a benefit in that. Repetitive exercises and repetitive visits is what's costing Medicare the most money. So, my goal is to cut down on the visits. I mean, if you've been bathing yourself for 70 years or 80 years and you have to have a knee replacement, do I really think that I need to come back in and show you how to wash your armpits? Probably not. So, there's a lot of visits that really don't need to occur, but I think we spend a lot of visits just because that's the most unsafe room in the home. So we've got a standard or a rolling walker here. We've already adjusted the wheels. This would be used by somebody who is probably getting ready to have their knee surgery. Once they've had their knee surgery, then they're going to be partial weight bearing. If they've had their hip surgery, then depending on the kind of surgery that they had, they may be non-weight bearing and do a step 2 gait. So that would mean my foot doesn't go on the floor. I move the walker out in step 2, step 2, step 2, step 2. It's a good thing I'm a moderately healthy 48-year-old man. I can't imagine in 30 years that this gets any easier. So that would be if I was non-weight bearing. If I was partial weight bearing, you saw the previous video where we were talking about the rollator, but in this case, it would be, putting 25% pressure on this foot. 50% is obviously as I stand, 75% would be 25% on this leg, 100% would be 100% on that leg. So just simple math, since there's only 2 feet, nobody has 3 that they use regularly, but I'm sure somebody's going to come up with a photo of somebody that does. So here we are. We got our standard walker, and we are here at the elongated office, my tiny bathroom upstairs, tub transfer bench. Still don't have the handheld shower installed, toilet safety rails, and of course the suction cup death bar, just to remind us how dangerous those things are. We have a 32-inch doorway here. The walker is narrow enough that I know that it's going to fit through here, so we don't have to worry about hinges or removing the door. We can still have a little bit of privacy. But in this case, obviously, if I'm partial weight bearing, the walker, it takes a little bit of work to get it over the little bump between the carpet and the tile here. But once we're in the bathroom, we can do that. We can do that partial weight bearing. Move the walker around. Get it situated, reach back for the toilet safety rails and have a seat, do our business, stand up, get over onto the transfer bench, take our shower while we're seated, and then get back to the walker once we've put our clothes back on after we've dried off and everything like that, and get right back out of the bathroom. They're pretty versatile. It's really a matter of balance and coordination. I think I saw a statistic that when somebody has a weight bearing restriction, that they are less than 50% of the time actually compliant with that. Which, if you think about it, if you're supposed to be non-weight bearing on an extremity and you put it down on the ground, that means that the bones are going to shift, the geometry is going to shift, and you might have undone what the surgeon was trying to do. Or at least, if you can imagine a bridge, if they're building a bridge and there's an earthquake and the earth moves, then it affects the way that the bridge lines up. And the same thing happens when they're trying to put in rods and everything like that to stabilize a major fracture. So pretty mobile. It would just be a matter of making sure that our interventions were brought to bear. That would mean getting the appropriate equipment in there, getting it installed properly, and everything like that. Which that takes a village. We really required the closing of the circle, the four people, obviously the doctor or the patient identifying as a fall risk, getting a home safety assessment by an occupational therapist who's specially credentialed to make those recommendations, getting a company involved who's able to deliver that equipment. There's plenty of DME providers around, but they're not going to carry some of the specialty equipment that we recommend. They really have their standards that they deal with because they like to just be reimbursed by Medicare. So we do have a company here locally that is able to deliver any piece of equipment that we recommend, and set it up, and their insurance covers that. And then, of course, bringing in home health. There's still a use for skilled home health once these things have happened, because perhaps they still have an incision and we have to keep the water off of it. So that'd be a good opportunity for the OT to work on those things. The OT to work on how to address after you've had a knee replacement and you can't get your socks on. Obviously the PT to do a little bit of ambulation. But most of that, as far as ambulation, should be occurring in outpatient therapy, not lingering in home health, where the visits are much more expensive. The visits are a lot shorter, and typically don't have the outcomes that people are looking for. They want to be able to walk better. They want to be able to walk more distance. They're not going to get that by walking around the cat litter box and down around the dining room table and then dodging the couch and around the ottoman back to the recliner. They're going to get way more ambulation if they go to outpatient therapy. But that's just one therapist's experience with thousands and thousands of patients. So again, if anybody differs in that, feel free to let me know in the comments. If you've missed the other videos, including the knee scooter or the rollator, feel free to go back and check those out. There's a couple videos on there as far as my opinions about grab bars. If you notice, I did all of that without a grab bar. Again, if we're talking about weight-bearing status because of a lower extremity surgery, probably not a good idea to be challenging gravity and standing up in the bathtub. Just, the juice isn't worth the squeeze. If you fall down and break your head, then somebody's going to be feeding you with a spoon, and all you did was just break your ankle, and that's not good. So, it's just better to take an ounce of prevention for a pound of the cure. So I'm gonna get out of here with my rolling walker. Y'all have a good day, and be sure to check out the wheelchair video coming up next.